So we have evolved, the man has evolved from the premier, and so the spine surgery has also evolved from traditional open spine surgery to microdiscectomy to endoscopic spine surgery to microscopic spine surgery, and now robotic spine surgery. So robotic spine surgery, in robotic spine surgery, there are mainly 3 robots which are into practice right now. One is Major X, another is ROSA, and third is Excelsis GPS. So something about these robots. So mainly the Major got FDA approval in 2004, ROSA got in 2016, and Excelsis GPS in 2017. The pre-op CT is required in Major, but is not required in ROSA and Excelsis GPS. In Major, the mount is on the bone, the patient bone, and the table, while it is a floor mount in ROSA and Excelsis GPS. Instrument tracking can be done in all the 3 robots. And the K-wires are required only in Major and ROSA and not in Excelsis GPS. Now in spine surgery, mainly the robot is used for complex spine deformities, like we are seeing in this picture, around 80 to 100 degrees of scoliosis, kyphotic deformities, or in revision spine surgeries where you don't get proper landmarks for screw insertion. So these are the surgeries which really in which the robot is useful. And also in such type of surgeries in which she is a 30 years old obese female having lytic listhesis at L5S1, in which your screw placement, robot helps in guiding your screw placement. And also if you are doing it through MIS, so it is in a perfect way. So what are the problems with MIS surgery? Mainly they require much longer exposure of radiation. They have a steep learning curve. There are 10% chances of misplaced screws and 0.8 to 2% chances of nerve injury. So how does the robot helps in this? So robot makes our screw precision more better. So we can do it in a smaller incision. So there is minimum blood loss, there is less hospital stay, less post-operative pain, quicker return to post-op activities, and minimum complications. So why robotics? We can do it even through a normal microscopic spine surgery also, but robot helps us in pre-operative planning. So it reduces the need of intraoperative x-rays. As you pre-plan your screws, so your operative time also reduces. So your 50% of surgery you have done before the starting only. So there is less radiation exposure in the operating room, and there is no need to wear lead aprons. So obviously the spine surgeons also get less amount of neck and back pain. There is less cancer risk also. It provides a stable rigid channel for guiding the surgical instruments. So because as we know, in spine there is hardly 2 or 3 mm variation also can disturb your screws. So it should be very perfect. So the stable rigid channel helps you to guide to put your screw perfectly. It eliminates the error of human hand, and the learning curve is also not too much for robot. So there are some studies which have been done in the literature. So first of all, looking at spine, it is present in Spine Journal 2011, which clinical acceptance and accuracy and assessment of spinal implants. It was done at 14 medical centers. 3,271 implants were put with 98.3% accuracy. Also another study in Euro Spine Journal 2013, which assessed revision deformity patients. 960 implants were put with almost 98.9% accuracy. One of the other studies which was published in Euro Spine Journal 2011, so it concluded that the robotics, the implants put with robot improved implant accuracy by 70%, reduced X-ray dosage by 56%, reduced complication rate by 48%, reduced reoperative rate by 46%, and average length of stay was reduced by 26%. Also, there was another study in Neurosurgery Journal 2013, which was a prospective study, which showed that use of robot increased the accuracy by 99%. So robotic spine surgery was mainly done for dorso and for putting dorso and lumbar screws. But it is also used nowadays for putting S2LR iliac screws, transpedicular and transdiscal screws for oblique lumbar interbody fusion. It is also used in the treatment of primary spine tumors and osteolysis associated with metastatic spinal disease. Also used for posterior cervical instrumentation, C1, C2 fixation, and SI joint fusion. So there are some limitations of robotic spine surgery. First of all is its cost, which cannot be afforded by each and every medical center. There are very few prospective studies which have studied the efficacy of the newer robots, that is XLZ, GPS, and ROSA. And there is some soft tissue pressure on the instruments through a robotic arm which causes skiving or deflection. There are a lot of future perspectives or future ways to look forward. Better integrated software systems can enhance the robotic interface and give real-time feedback so as to how precisely a robotic implanted screw is deviating from the pre-planned trajectory. You can know that. Artificial intelligence and augmented reality are integral components of robotics, and as this happens, it will be able to anticipate dynamic changes in trop, and further it will enhance the accuracy and efficacy. Future robots will also help in guiding the surgical decompression and also guide intradural tumor, extradural tumor resection. And well-defined RCTs, prospective studies are required for the patients with robotic spine surgery. And being exposed to the surgeon's screw planning preferences, robot over a period of time will be able to automatically plan the screw for you, and also will compare the inter-surgeon variability also, so that it can tell you over a period of time that irrespective of the geographical location of the surgeon, of what the exact placement of screw should be. So ultimately, lastly, robot doesn't replace the surgeon, but for an experienced and good spine surgeon, it can push the boundaries in tackling some extremely complex spine deformities. The robot doesn't make a bad surgeon good, but it makes a good surgeon more efficient and precise. Thank you.